Numbers of patients come from their work. So I started to learn oncology from Dr. Jerry and Dr. Carol Shields 5 years ago. The impression comes to me when I met Dr. Jerry Shields in World Ophthalmology Congress in Hong Kong. He talked about PLSU, which is the removal of the tumor surgically from the posterior choroid, from the choroid. And it's very impressive. I'm trying to stalk him all the way through the meeting to have the chance to talk to him. Could I be his fellow? So I talked to him, and he said, okay, you can be our fellow. So I asked him, when should I do the interview? He said, okay, this is your interview. When will you come? So that's how I get to learn oncology from them. The 1 year experience over there is really helpful and wonderful for me to start our oncology practice in Thailand. We are now having plaque brachytherapy, intraocular chemotherapy, almost all the facilities that the modern world have, while we don't have for many, many years. So thank you very much for joining us, and this would be the wonderful opportunity from you to learn from the best. Welcome, Dr. Jerry Shields.
And first I'd like to introduce my partner in crime. We have Dr. Carol Shields over here. You want to say hello? And I guess we're going to probably have enough chairs, but it may be a little crowded.
Can I just welcome
Yes.
all the people in? If we can make room for people to sit down. I also want to note that Dr. D was a wonderful fellow, and we're really proud of what she's done here in Thailand. I'd want to recognize Dr. Furuta, who's in the audience. He was a fellow, and he's done a lot of ocular oncology work in Japan. So we all work together worldwide. And Dr. Wan is here from Thailand. She's a current intern with us.
So we have several of our ex-fellows here, as Carol said, so if any of you are so inclined, we'll take more applications today, okay? Anyway, we're going to get started now, and this is going to be a fun course. I'm not going to give a talk per se. We're going to have a lot of audience discussion, answering questions and everything, okay? So let's get underway. We're from the Oncology Service at Wills Eye Hospital in Philadelphia, Thomas Jefferson University. And we do have the 3rd edition of our textbooks that just came out this year. And one is on intraocular tumors, and the other on eyelid, conjunctival, and orbital tumors. And
If you lift it up and point it to the back where he is. Arrow right.
yeah, the 3rd edition includes a lot of things that weren't there previously. We have about 5,000 high-quality illustrations, a lot of new material, new cases, and it's organized in a way that we have not just clinical information, but also pathology. So there's clinical pictures, pathology and treatment of virtually every condition, lump and bump around the eye. So I don't know if it's here at this meeting or not, but you should know it exists and can be obtained through Amazon, right?
Yeah. If you go to Amazon.com, it's available there.
Right. Okay, now, we're going to start by asking you all a simple question, and we'll get a few more people in, I guess. What? Okay, there's more seats. We're going to have a lot of discussion, and Carol is going to be commenting a lot. I'm not doing all the teaching for sure, and all of our ex-fellows here are welcome to comment as well. We'll try to get through all the material we have in time, but also make a lot of points that will keep everybody awake. First, I have a question for the audience. How many people have seen any of these? If you've seen any of these conditions, raise your hand. Good. That's a good start. The next question is, oh boy. How many of you have seen all of these? Raise your hand. Okay, very good. So I have news for you. How many people came to hear about tumors? I got sad news for you. Because we're going to discuss these conditions. And I'm going to start by mentioning astigmatism, chalazion, conjunctivitis, and so forth. And for those of you that came here to hear about tumors, I deeply apologize for that. And these are things that you're more likely to see in your practice of ophthalmology. So let's get started. And let's first talk about astigmatism. What do you do when you see a patient with astigmatism? And it's difficult to correct with your refraction. What should you do next? Well, you dilate the pupil in our practice and look at the ciliary body, because you may be surprised to see a ciliary body melanoma right there at the spot. Now, why the astigmatism? Because from time to time, the ciliary body melanoma, as shown in this specimen here, is pushing on the lens equator. And sometimes that's the first sign of a ciliary body malignancy. Astigmatism by pushing on the lens equator. If anybody has any comments, go ahead.
So probably every 2 months in our practice, we will have a patient in with a ciliary body melanoma. We see ciliary body melanomas every week, but about every 2 months, someone will come in with a clear lens and cataract surgery, which the lens was clear but removed because it had a little bit of cataract, and there's a ciliary body melanoma hiding out. So if you have asymmetric cataract or asymmetric refraction, you really have to dilate and look in the ciliary body, make sure there's not a mass.
Okay, and that's what's coming up next. So the next is strabismus. All of you see strabismus in your practice, right? A child presents with esotropia. You should tell the parents, go back home and patch, and we'll see you in 6 months, right? Not necessarily so, because in some cases, that's due to a white pupillary reflex, and even a relatively small retinoblastoma can be in the posterior pole and disrupt fixation and cause leukocoria. What percent? We see a lot of patients with retinoblastoma, many each week. And Carol, how often do they present with esotropia?
I'd say maybe 20-30% have esotropia.
So you have to think.
It's usually from a tumor in the macular region.
So you have to think of that, okay?
The older kids that come in with retinoblastoma tend to have more peripheral tumors because they're not disrupting fixation. It's those that are real young tend to come in with the macular.
Right. Okay, what is this diagnosis? Anybody? Okay, this is achalasia. Why are we talking about chalasia? Well, there's another chalazion. It looks a little different. There's loss of cilia, and it's in an older person. What do you think of in these cases? Anybody? More common in this part of the world, right? Sebaceous carcinoma. Sebaceous carcinoma accounts for about 5% of eyelid malignant tumors. It's malignant. It can metastasize to regional lymph nodes and beyond. And how many people in this room have seen it? Most of you are from this part of the world, and it's very common, right? You have to think of it. Here's another one showing the classic loss of cilia and the yellow color to these lesions. Okay, here's another eyelid nodule. It looks like a chalazion, but I wonder what this could be. We're going to teach you some new things today you may not know about. But this diagnosis is a Merkel cell carcinoma. This is a neuroendocrine tumor that can occur on the eyelid, usually the upper eyelid, and has this red appearance to it. Merkel cell carcinoma occurs in older patients. It has a reddish blue color. It's sausage shape, usually in the upper lid, and metastasis and death occur in about 25%, according to the literature. More recent studies have suggested it's not that aggressive or malignant. Okay, here's another chalazion near the medial canthus. You can see it here. What do you think that might be? Anyone? Well, this was a metastatic tumor from breast to the eyelid. Breast cancer can present in the choroid, as you know, before the breast cancer is known, and it can also occur in the eyelid. Okay. Here's another chalazion, but it got worse. It was bilobed and red in color. And does anybody want to comment on what that might be?
I would say beware the chalazion with cilia loss. They can certainly cause loss of lashes, but I mean, all the lashes are missing here. It suggests something infiltrative.
Okay. This happened to be not a chalazion, but this was eyelid metastasis from a kidney cancer. Okay? So we can see different cancers presenting in the eyelid, even though they may have retinal significance. You can see that this patient had a yellow lesion in the choroid, a yellow-orange lesion. And that brings up the subject of metastasis that appears yellow or red or orange in color. What are the differential diagnoses of orange-colored choroidal metastasis? Bronchial carcinoid is the most common, but you can see it with some cases of thyroid cancer, renal cell carcinoma, and rarely others. Okay? So you have to think of it and always check the fundus of these people that have something like that. We've made the diagnosis of bronchial carcinoid tumor in our office as an ophthalmologist by looking at this fundus. And we call the doctor back home and say, we think your patient might have a bronchial carcinoid. And they'll say, what are you talking about? You're an ophthalmologist. We're often right by seeing the orange-colored tumor in that area.
Yeah, carcinoids can be very tiny tumors, about the size of this tumor. This wasn't a carcinoid, this was a renal cell carcinoma metastasis. But when you see small orange multifocal tumors, you really have to think of bronchial carcinoma. It might be completely asymptomatic in the lung. We had a patient come in just 2 or 3 weeks ago with a metastatic carcinoma to the uvula.
Mm-hmm. Okay. Eyelid metastases are uncommon, but as we showed you, they can be the first sign of a cancer or the first sign of metastasis from a known primary. Often misdiagnosed as a chalazion, and breast, lung, melanoma can all occur. And most of these patients will end up dying of metastatic disease. So take some of these chalazias a little serious. We've listed here a number of cases that can simulate chalazion: sebaceous carcinoma, basal cell carcinoma, Merkel cell carcinoma, and others. It is important, if you do chalazion surgery, to send pathology to your pathologist because they sometimes will find a malignancy there that you didn't suspect. Do all of you send your specimens to the pathologist as a rule? Not everybody does, right? Here's another case. What is this? All of you have seen this. This is, anybody? Blepharitis. It's common in every practice. Typical features, conservative management. And here's another case of blepharitis, but it's a little different. There's loss of cilia there, isn't there? Yeah. And this happens to be another case of sebaceous carcinoma. Even though they arise from the sebaceous glands, they can wipe out the eyelid pretty aggressively like this. Any of our fellows or anything, any ex-fellows has anything to say, just speak up. We did some studies on this, and the epidermis was involved with these chalazia. which were sebaceous carcinomas in about 1/3 of the cases. Another case, I'm just going to go through these, of another what looks like a blepharitis inferiorly, but there's loss of cilia once again. And this was a basal cell carcinoma of the morpheoform or diffuse type. It doesn't look like the typical basal cell carcinoma, does it? So eyelid basal cell carcinoma can be morpheoform in appearance. It's got a diffuse thickening of the lid. There's no central crater like you see with most basal cells. And this is a very invasive tumor that can get into the brain and be fatal. So we've talked about some cancers that can simulate blepharitis. Let's go on now and talk about some more. What's this? Common thing, this is acute conjunctivitis. And it's a common disorder, typical clinical features, many causes, and you know the treatment. So here's another case of conjunctivitis, but it looks a little bit atypical, doesn't it? It's got some peculiar corneal involvement. This was another case of sebaceous carcinoma, which, as you know, is more common in this part of the world.
Well, that sure looks like squamous cell carcinoma of the conjunctiva.
Sure did, didn't it?
You know, it has that gelatinous look, it's onto the cornea.
Yeah.
So there must have been a primary in the lid at some point. Although you can have primary sebaceous carcinoma in the conjunctiva alone, most of the time it arises either in the sebaceous glands in the eyelid or the sebaceous glands of the caruncle.
Okay. Here's another one of a sebaceous carcinoma that presented with corneal involvement. The whole cornea was opaque and the diagnosis was not recognized. So in a large study that we did, conjunctival and corneal epithelial involvement by sebaceous carcinoma does occur, and it's quite possible that you've seen that in this part of the world as well. So eyelid sebaceous carcinoma, there's two main presentations, a nodule on the eyelid, which resembles a chalazion initially, and a diffuse variant that resembles blepharitis or blepharoconjunctivitis. And there's frequently misdiagnosis. You just don't think of it. Here's an example of a patient who came in with, you can point if you want, on the right eye you can see there's, this lesion had been treated by a cornea specialist and an oculoplastic surgeon for about 2 years with the diagnosis of blepharitis. And when she finally developed this appearance that you see with her lid closed, it proved to be lymph node metastasis from the sebaceous carcinoma. So they can be highly aggressive and metastasize to regional lymph nodes. Here's another case. It looks like, well, this is a rodent ulcer, isn't it? It's an ulcerated lesion in the lower lid, medial canthus, and it looks like keratoacanthoma, right? But looking closer, it's pedunculated. It's interesting. And this proved to be, on low power, what looked like a basal cell carcinoma. An excisional biopsy was done, and it looked like basal cell carcinoma. You see the rodent ulcer up there in the blue color?
But basal cell carcinoma would be so unusual to occur on the mucous membrane.
Right.
But it can occur in the caruncle, because the caruncle has epithelium similar to the skin. So you can sometimes get basal cell carcinoma in the caruncle. It'd be really rare to see it on the bulbar conjunctiva.
But this lesion surprised us. It was not any of those things. It was a malignant melanoma. Surprised us completely. You can see the melanase stain and the typical melanoma cells. So this was a melanoma that simulated a keratoacanthoma. And it can fool you sometimes. It's a highly malignant neoplasm. Now next, let's look at this. Here's something that you may see in your practice. Painful lesion with a lot of blood vessels. What's that? Anybody? That would be possibly scleritis or episcleritis, right? And you all see this in your practice. Even if you're a retina specialist, you're going to see it. They get pain. So here's another case of similar nature. What would be the diagnosis here? This was a scleritis, but it didn't respond to steroids. It wasn't getting any better with steroids. If anybody wants to go to the squeeze in back there, they can. Didn't get any better with steroids. What do you start to suspect? These are sentinel vessels. And what are sentinel vessels? They're dilated blood vessels over a ciliary body melanoma. Okay? And you can see the patient history. This patient was a lawyer from New York City that was given steroids for a year because of this cosmetic blemish, as it was called. Later developed vitreous hemorrhage, came down to see us, and at that time the large ciliary body melanoma was found after a long delay in diagnosis. So this was a poor response to steroids, and look at these carefully because this is a sentinel vessel, and these sentinel vessels are a sign of underlying ciliary body melanoma. We saw one just last week, just like this, presenting with the sentinel vessel. Any comments?
You know, there's another condition called scleral macrovessel and conjunctival macrovessel. Occasionally those patients get sent in to rule out a ciliary body melanoma. So we go through the full workup. We'll do transillumination of the eye to see if there's a shadow in this area, and we'll also do an ultrasound of the eye, and even ultrasound biomicroscopy to see if there's a mass. So some of these patients with, quote, sentinel vessels actually just have scleral macrovessel or conjunctival macrovessel, not a tumor.
So these are sentinel vessels. You should know about them, and we gave you the patient's history. Had steroids for a year, and ultimately, after it was finally recognized, he died of metastatic disease. And the ophthalmologist had treated him for scleritis for these drops for a long time without recognizing the melanoma. So whenever you see a sentinel vessel, just like the first case I showed, you need to dilate the pupil widely and look at the ciliary body, as Carol said, do UBM if necessary, and you might pick up an occult melanoma that you wouldn't see otherwise. Okay, ciliary body melanoma. Okay, here's another patient. I wonder what this diagnosis is. It's got some white discoloration. It's a conjunctival metastasis from breast cancer. So I've showed you several things of breast cancer that can metastasize to various parts of the eye. Often there's choroidal involvement in these cases as well. And what's the diagnosis in this case? These two? Common, aren't they? Everybody knows what this is. This is a chalazion and a pinguecula. And they are quite typical in most cases, but it's well known that neoplasms can simulate these benign conditions. Here's another patient that came in with what looked like a little chalazion, or a pinguecula. But as you look at this, it was invading the cornea, it was a little bit different, and this proved to be a squamous cell carcinoma. So they don't always prove to be benign. If you do a biopsy of one, try to get pathology. Just to close with squamous cell carcinoma, here's a number of pictures of squamous cell carcinoma. And look at the wide variety of them. They don't always look the same, do they? So here's a patient who sent in for this choroidal lesion. Is that a melanoma? How many people think it's a melanoma? Nobody, right? This looks like a nevus. But the technician who was there happened to take a look at this thing and call the retina specialist, who said, well, there's no melanoma in the fundus, but what is this thing up here? And this proved to be a malignant melanoma.
I have to admit, that's a pretty atypical looking amelanotic melanoma.
Yeah.
But, you know, when you see these dilated vessels going into it, you really start to think that there's something unusual about this. Because it sure does look like a pinguecula.
Yeah. And the diagnosis, baseline photographs, it was no melanoma in the fundus as suspected, but it was a melanoma discovered by the retinal photographer because the retina specialist wasn't too worried about it. Okay?
The arrow forward.
Here's another patient, a young man who presented with a long history of drops for a red eye. Okay? What could this be? Well, when he got into us, you can see that he had this lesion. It was starting to get a little bit of pigment, and by that time he already had metastasis to the preauricular lymph nodes from a melanoma. Another long delay in diagnosis where the diagnosis was not suspected.
Yeah, he was labeled as an unusual hemorrhagic conjunctivitis and told to go home. And a couple months later, he re-presented to the ophthalmologist, and then they saw the little bit of pigment, and they started worrying that maybe this could be a melanoma. By the time we saw him, he already had a lymph node metastasis. You got to be, those hemorrhages in the conjunctiva, you probably should see the patient's back and confirm that the hemorrhage is gone before you call it a hemorrhage.
Okay? So remember, conjunctival squamous cell carcinoma and melanoma can simulate these benign conditions. If the lesion is atypical, consider complete removal. Don't just do a small biopsy of these lesions. Okay, here's a patient who, this is just a description of how we manage conjunctival tumors, which is beyond the scope of this group here. But we do treat anywhere between 4 and 8 new conjunctival tumors each week in our practice. And we have a technique of how it's done that's all published. So we won't go into it here.
Can I make it one point, though?
Yeah.
Okay, if you go back. So melanoma, the management of melanoma is surgical excision, nothing else. You always must remove a melanoma. Eye drops don't work. But for primary acquired melanosis that can lead to conjunctival melanoma, you can sometimes get away with using topical mitomycin C. Some people have even found that interferon can be of use. We have not confirmed that yet. Now, on the other hand, squamous cell carcinoma, you can use many different ways to treat that. You can surgically resect it, or you can put the patient on mitomycin C, 5-fluorouracil, or interferon, or even inject interferon, or use cidofovir. So there's a lot of ways to treat squamous cell carcinoma. But melanoma, there's basically one way to treat it. You have to remove the tumor.
Yeah. So we're going to show a lot of pictures of how the surgery is done, but that's beyond the scope of this particular group. Here's another patient who presents with a red eye. What could this be? You see this in your practice every week, right? This is a spontaneous, what? Conjunctival hemorrhage. Straining at the stool, all kind of problems. So here's another case of another lesion that looks like, what could this be though? Okay, this happened to be Kaposi's sarcoma. Kaposi's sarcoma is an interesting tumor that looks just like a hemorrhage in many cases, and you're going to confuse it with a hemorrhage. That's Kaposi's sarcoma. We used to see it a lot in the conjunctiva, but not so much anymore because of the AIDS has been largely eliminated in many places.
Yeah, especially in the past we used to resect these and cryo these Kaposi sarcomas. Now all we do is lift up the telephone and call the HIV doctor and ask them to increase the heart level, and it causes their Kaposi sarcomas to go away.
Okay. This is another case that we saw near our hospital, and was a person that we all knew. He was asked to come back for a follow-up visit, and he died within 2 weeks after we saw him with advanced AIDS several years ago. Okay, let's go on now to talk about something else. We're going to talk about something that is dear to our hearts. What's this? This is a cataract. And we came here to talk about cataracts today, right? So there you are. That's a cataract, right?
Does anyone see anything funny about this cataract? They're pointing to this, Jerry.
Yeah,
it has a little brunescent look up there.
Yeah. Okay, starting to get suspicious, right? It's a unilateral cataract. The other lens is perfectly clear. It's a unilateral cataract with a poor fundus view. And here on your next, I'm going to show another similar case that came to enucleation. And you can see the peripheral ciliary body melanoma there compressing on the lens and producing a cataract. And once or twice a year, we'll get a call from one of the cataract surgeons at Wills Eye Hospital, and they'll say, I'm worried, I'm starting to do a cataract, and I see something funny there. We run up to the operating room and recognize the melanoma. So all cataract surgeons should be alert to that possibility. Here's another case that had the cataract successfully removed. You can see the nice clear IOL, but on the first post-operative visit, it was resting on the dome of a ciliary body melanoma. So surprise to the cataract surgeon that that's happened, and we have a number of such cases. So the question comes up, some of these cataracts are discovered at the time of surgery, and the melanoma is recognized and the cataract surgery is aborted. Others are discovered at the first postoperative visit. And how can you, if you do cataract surgery, recognize an occult ciliary body melanoma before you do the cataract surgery? What should you do? Anybody? Well, first you attempt to get a good fundus view. If you can't do it, then look for those sentinel vessels that we talked about earlier. See the sentinel vessels? And then if you still can't see the fundus, you can do ultrasound. And with ultrasound, you want to use the pointer there, you can. With small melanomas, you can see the acoustic hollowness and the choroidal excavation. And with larger ones, they're actually almost pathognomonic when you see a breakthrough Bruch's membrane. So the cataract surgeon should know of these things and so forth. So here's the other thing you can do. If you're in a practice and you don't have an ultrasound and you do cataracts, you might do transillumination. This is a forgotten art in ophthalmology, but very important. If you take a bright light and put it in the conjunctival fornix, that light will come through the pupil quite nicely, and it will cast a shadow corresponding to the ciliary body melanoma that you see over here on the right. So even if you don't have ultrasound, if you can do transillumination, ciliary body melanomas can be recognized. Any other comments on that? How many people have seen that? A few people? Okay. Here's another story of a patient who comes in for LASIK surgery. How many people do that here? Quite a few? Only a few, a handful. But the cataracts, the LASIK surgeon was pretty sharp. He lifted up the lid and saw something pigmented up there. Sent the patient in to us, and what do you do next? Ciliary body pigmented lesion.
What is this, a nevus? What do you guys think as you look at it? There's some clues there that tells you what it is.
Sentimental.
It's got somewhat. Go ahead.
So the color is really dark brown. It makes you think of something melanocytic. But if you look right here, it's under Tenon's fascia. And so a nevus is superficial to Tenon's fascia. And PAM is superficial to that in the epithelium. So it's not likely PAM. It's not likely a nevus. It's likely something that's deep to Tenon's fascia coming out of the eye.
So having seen that pigmented lesion in the sclera deep to the conjunctiva, we did UBM. And there you see the ciliary body melanoma, and the patient went back home with a radioactive plaque instead of getting LASIK surgery. So sometimes we change the course of what's going to happen. Okay? So here's something else that's well known to ophthalmologists. What does this patient have? We start asking questions. Is the heterochromia congenital, or what's the cause of the heterochromia? Well, this patient was a young guy who said, well, the iris just kept getting darker and darker. What could that be? Any comments? So, there he is, heterochromia.
Yeah, when he was a young child, he had 2 blue irides. And then as he got older through teenage years, the left one became darker and darker brown.
That would be unusual for congenital heterochromia.
How many people think you know what this is? Raise your hand. A few people, maybe. Well, he had a syndrome consisting of acquired hyperchromic heterochromia and secondary glaucoma due to angle involvement by pigment, unilateral. This is a diffuse iris melanoma. Unlike the typical iris nodule where you see a nodule, these produce hyperchromic heterochromia acquired in adulthood. They gradually enlarge. There's usually a long delay in diagnosis. People don't think of it. And the management of these in the past was enucleation when this slide was made up. But we've treated a number of these now, even though you would expect to be enucleated, with plaque radiotherapy to the iris. And we can control the disease that way. Okay?
You know, if they have secondary glaucoma, we usually don't do plaque. We'll usually wind up doing enucleation. But if they have controllable pressure, we will put a plaque, if you can believe, right over the entire cornea. It's transcorneal radiation into the tumor and save the eye. With plaque for diffuse iris melanoma, we save maybe 92% of those eyes.
And here's another patient who had acquired heterochromia. The surgeon made the diagnosis of pigmentary glaucoma. What's wrong with that? It's usually what? Bilateral, right?
And it's not iris pigmentation.
What?
It's pigmentation on the endothelium and in the angle. It's not iris pigmentation.
Right. So the patient had a filtering bleb 2 years earlier, and that brings us to Tales of the Black Filtering Bleb. What do you think? Because now the filtering bleb was filled up with melanoma cells, and the glaucoma specialist then decided, well, maybe I was wrong. It could be a melanoma after all. But that's one of the tales we have of the black filtering bleb, and we've seen several, right? Let's go on to some pediatric cases. What about pediatric iritis and pediatric glaucoma? Here's a young child who presents with a different colored iris on the right side. What do you see there? You see what? Blood vessels, right? This child has neovascularization of the iris. What's the cause? What are you going to worry about if you see iris neovascularization in a 2-year-old child? Anybody? No? Here it is. Secondary glaucoma. Diagnosis, if you look carefully, you start to see something in the right pupil. What is that? Yeah, leukocoria. So this is a child who indeed has retinoblastoma. Now, how often do we see patients who present with retinoblastoma in this manner before the tumor is recognized, Carol?
Maybe about 20% of them have NVI.
Yeah.
So of all kids who come to see us with retinoblastoma, about 20% have NVI. When I see NVI in a child, the first place I look is the retina. And you want to look for a retinal detachment, Coates disease, retinoblastoma. Then if that's negative, I look in the ciliary body because I want to rule out medulloepithelioma, which commonly produces NVI and NVG. And if that's negative, then I look really carefully at the iris to see if there's either a nodular or flat JXG. So those are all the things we think of when we see NVI in a baby. Because in adults, when you see NVI, you think of diabetes, CRVO, ocular ischemia, but you don't think of those in kids. It's completely different.
By the way, it's crowded back there, and it won't disturb me or us if you guys want to come up and come by and get on the other side of the room. It's quite all right. Go ahead. We'll just keep going. You want to get up there closer. Good. So this is a retinoblastoma that presented with neovascular glaucoma, and you can see that, what percentage of our cases again present with neovascular?
About 20%.
About 20%.
So Jerry, you showed this enucleated specimen on this eye that had NVI from retinoblastoma, but guess what? Nowadays, this eye wouldn't be enucleated. This eye would have been treated with intraarterial chemotherapy. The tumor would have responded and the NVI would have gone away.
Yep.
So we do treat eyes that have NVI with systemic and intraarterial chemotherapy.
And we didn't plan to give a talk on retinoblastoma today, but you should know that because that's very important. Okay, here's a patient who presents with acute congestive glaucoma in an adult. You see there's a cataract, red eye, and in this case, if you look carefully, you'll see on your right the melanoma that presented with neovascular glaucoma before the melanoma was even recognized. And that's an unusual presentation, but it still occurs today. I think this patient was treated for a period of time by good doctors with for central retinal vein obstruction and for diabetic retinopathy and all kind of things, and nobody thought of the melanoma until it became painful and the eye was enucleated. And you can see the melanoma on the right and the total retinal detachment and the lens being pushed forward, lens iris diaphragm. So melanoma can still present that way in this day and age. Here's another man who presents with what was thought to be a vein obstruction for a while and so forth, and I think he had diabetes. And in this case, this also proved to be a malignant melanoma. You can see the CT here that was done several years ago, showing the eye being filled with melanoma and the orbit being filled with melanoma. So a lot of these patients, less common today, present with a history of glaucoma that's been poorly treated and hasn't got under control. Here's another interesting lady that really fascinated us. I think she had a history of diabetes, and she had orbital involvement. And what do you start to think of? Mucormycosis, right? And that's what she was thought to have. And in her case, it was a blind eye, and we did a CT at that time, and you can see that the whole eye and the whole orbit is filled with this massive tumor. Now, at that time, we noted that the tumor was filling the eye and the orbit, so we did an orbital excitation. And you'll see there the globe to the left filled with melanoma cells, the orbit back there filled with melanoma cells, and it was streaming back the optic nerve toward the chiasm, a very aggressive melanoma. And in this case, it was very interesting. This patient had no metastasis. We did the orbital excitation. There was tumor cells almost back to the chiasm. They cut the chiasm, took everything out. And this lady proved to be very interesting because, go back one, that tumor was composed of pure epithelioid cells, highly malignant melanoma, long delay in diagnosis, invading the optic nerve. And this lady lived another 6 years, never developed any melanoma metastasis at all. It's weird because I showed you earlier today in a talk how many of these patients will present with small melanomas, almost nevi, and they metastasized.
Well, she had no symptomatic metastasis. I'm sure she had melanoma all over her body, but her immune system just held it in check.
It's very possible, yeah. I would suspect the same. It was a highly malignant tumor that developed no metastasis while she was alive. So here's another patient who presents with a lesion below the disc. It's kind of hard. It was an African-American woman. She was 57 years old, and she had a positive gallium scan, I was told, and sarcoidosis was thought to be the diagnosis. It looks like a sarcoid granuloma, but she developed severe pain, no light perception, and subretinal hemorrhage. And we enucleated the eye, and you can see the red blood to the left, and all the way down at the bottom there's a white lesion that proved to be a medullary carcinoma, papillary carcinoma of the lung metastasizing to the eye and presenting what looked like sarcoidosis. So this was a metastatic papillary carcinoma from lung simulating sarcoidosis and fooled a few people. Now the next thing we're going to show is this. This is a 6-year-old. We'll leave retinoblastoma. We're tired of talking about that, right? And we're going to talk about a hypopyon in a 6-year-old child. What would cause a hypopyon? Well, there's no signs of much inflammation there. It's kind of a quiet eye. Anybody? Yeah. This was a spontaneous hypopyon in a quiet eye in a young child. And the referring diagnosis was Coats disease.
You go back one?
Go back
A couple things are missing here. You know, everyone, when they use the term hypopyon, this is really not a true hypopyon. But when you see an infection with hypopyon, usually you have injection, you have posterior synechia, you have a painful eye, the patient's not comfortable. But when you see a, quote, hypopyon in a quiet eye, you start to think of tumors. And in a kid, you think of RB.
Well, the doctor sent the patient in with the diagnosis of Coats disease. And you see the fundus shows this yellow material, these blood vessels. That's Coats disease, isn't it? Well, I wonder. Because we were asked in a male consultation, this was also several years ago, what should be done about this patient with Coats disease, how would you drain the subretinal fluid, etc. And we wrote back and said, don't do any of those things, just take out the eye. Because this was very classic of not Coats disease, but when you look at it carefully, you'll see the mass. On the right, you'll see the diffuse white material. That doesn't look like a retinoblastoma, does it? but that is indeed a rare type of retinoblastoma called a diffuse infiltrating retinoblastoma. They're unilateral, non-familial. They occur in older kids. We've seen them up to 19 or 20 years old presenting with retinoblastoma. It stimulates inflammation, but there's no mass, no calcium, family history is negative, and in these cases there's frequently a misdiagnosis. And several years ago, Carol and our team put together a series of these, pointing out that we've seen retinoblastoma at every teenage year, from age 11 to age 20. So retinoblastoma is not necessarily a disease only of infants. And we took a study in...
Yes.
Yeah.
In this condition, can we drainage of the subretinal fluid for biopsy?
So can you do like a sample, like a needle
Yeah,
biopsy of the subretinal fluid?
Yeah.
I think the safest would be if you have anterior chamber cells to maybe sample those.
Yeah.
But as you're coming out with your sample, apply cryotherapy at the site where you're coming out.
Yeah.
So if there are some cells on your needle, you're at least freezing them. But I think just by the clinical features, you could make the diagnosis of RB.
Yeah.
Now, once you've seen it, you will. Now, here's a study that we did several years ago on 900 consecutive cases, and about 11 of those cases had previous pars plana vitrectomy because retinoblastoma was not even suspected. And here were the diagnoses: vitreous hemorrhage, toxocara, toxoplasmosis, and endophthalmitis. These surgery in these cases were done by the top vitreoretinal surgeons in the United States. You would recognize all their names. And when was the retinoblastoma suspected? Well, during the pars plana vitrectomy in 2 cases, on cytology that they did in 8 cases, and after referral to us in 1 case. So vitrectomy, we've taught in the past, can be dangerous in kids with retinoblastoma, because you may allow the retinoblastoma cells to get out into the extraocular tissues. It's getting a little bit better now, maybe, huh?
Yeah, so we never want to do vitrectomy on an eye with fresh retinoblastoma. But the question comes up, say you've already treated a kid for retinoblastoma, and the tumor's under control, but they get a rhegmatogenous detachment. Then that's where we kind of quietly consider vitrectomy for repair. But what we would do in those cases is we clean the vitreous with intravitreal chemotherapy, with melphalan. Or Dr. Jundaji from Shanghai, he will put melphalan in his infusion and then does the vitrectomy under BSS with melphalan to, in case there is any active vitreous seed, it's under control because melphalan is so powerful. So if we have to do vitrectomy in the States, we will inject sequentially 1 week, 2 weeks, 3 weeks melphalan, sample to make sure it's clear, and then let our vitrectomist do the surgery.
Okay, and we'll go on then. Here's another patient. A child presents with inflammation, swollen eyelid, diagnosis.
Cellulitis.
Orbital cellulitis, preseptal cellulitis, very common. But this proved to be a necrotic retinoblastoma. And you can see after enucleation the retinoblastoma cells filling the eye, producing orbital inflammation secondarily, looking like an orbital cellulitis. So any child with orbital cellulitis, you should consider the possibility of retinoblastoma in your differential, even though orbital cellulitis is more common.
Yeah, and look at the other eye. You can see the
look at the other
leukoporia there.
Okay. So in these cases, it's interesting. The radiologist is going to make the wrong diagnosis. The radiologist looks at the CT that was done. It shows the calcium in the eye, and the radiologist will look at the orbit, and there's all kind of stuff in the orbit. So they always say, well, there's a retinoblastoma in the eye, and there's orbital extension. They're wrong 100% of the time, almost. It's not orbital extension of the retinoblastoma. It's secondary inflammation and necrosis from the lesion itself.
So sometimes this cellulitis can be so bad and so swollen that the eye is shut and you can't even open the eye. And so I know of cases where these kids will be put on a week of steroids to try to reduce the swelling before you go to enucleation. These are usually really eyes that are shot. They're very sick eyes. The tumor is very necrotic. There's no hope for salvage of these eyes. So you might want to even put the baby, since this is bilateral, on systemic chemotherapy, shrink down the tumors, and see, you know, what happens to this eye. Often these eyes come to enucleation.
Okay.
We don't jump to enucleation nowadays as we used to in the past.
Here's another case of an elderly woman who did have diabetes, poor control, and she developed acute orbit, as you see here. In her case, it was thought to be mucormycosis because she was a diabetic out of control with all of this inflammation. And in her case, it proved to be a necrotic choroidal melanoma. Very necrotic, suggesting an inflammatory process in diabetes. If you look on the right there in the globe, you can see the mass, and on the left you can see the big hemorrhage. And so necrotic choroidal melanomas can occur, and you have to think of it in the differential diagnosis, even though they may have diabetes or other conditions. Okay, now let's going to say a few words about anterior vitreous hemorrhage. You all see that in your practice from time to time, usually rhegmatogenous retinal detachment, diabetes, and so forth. A 55-year-old man comes in with the right eye normal, and the left eye has pain and light perception vision, and ultrasound shows this big hemorrhage filling half of the eye. Well, is it really hemorrhage? Because as we looked at this, it looked like a possible melanoma. So we enucleated the eye, and you can see the retinal detachment with a hemorrhagic mass there. Everybody see that? And the hemorrhagic mass, after enucleation, proved not to be a melanoma. We were wrong. This was a uveal metastasis from a young lung cancer. The patient did not know they had lung cancer, and they presented like this. So you have to think about it in your differential diagnosis. Here's another case that was sent to us from down the street in Philadelphia. A woman came in with, the doctors down the street said she has central serous retinopathy, I think. Can you guys take a look? We looked at it, and lo and behold, there were these yellow lesions in both eyes. We called her husband aside and whispered to him, your wife may have lung cancer. What are you talking about? Because if you see bilateral lesions like this with a clear vitreous and no signs of inflammation in a woman who's non-smoking, it is sometimes lung cancer. It presents, this is so typical here. It's not multifocal choroiditis, there's no inflammation and so forth. Any comment?
Yeah, the only other thing it might simulate is VKH, void Koyanagi-Harada syndrome. Can have these yellow lesions, but your OCT would look a lot different.
Yeah.
So you can differentiate them based on many things.
Now we went back into the room, and he said, what are you talking about? So we went in to tell the wife, we said, we're going to have to get a chest x-ray if you don't mind today. And she said, why? And we told her, well, this is a possibility of being lung cancer. She said, oh no, I'm going to Israel next week for a month, and I don't want this and that. And so she changed her mind in a hurry. This proved to be lung cancer presenting what looked like multifocal choroiditis or inflammation. So breast cancer, if you see breast lesions like this in a non-smoking woman, you should think of lung cancer, but breast cancer also. But breast is not the most common. In cases like this, in women, lung cancer is more common.
I mean, if you look at all Mets to the eye, to the uvea, in men, the most common primary site is lung. In women, it's breast. But if you look only at those patients who have no history of cancer and come in to see you with a Met in the eye, it's lung for men as the primary and lung for women. So lung cancer has this tendency to manifest in the eye before it's symptomatic in the lung. So if the patient denies cancer, it's probably lung cancer. You tell your radiologist, chest x-ray. And if chest x-ray is negative, you tell them chest CT.
So I think we do have 15 more minutes. This is supposed to end at 15 after, so we'll move along and get through a lot of good cases for you, I hope. So what is this? Anybody? What do you call that? This is chirpy. congenital hypertrophy of the retinal pigment epithelium. It was talked about in the last session. And it's a benign lesion. You can see the depigmented lacunae. Everybody in retina has seen it, right? All of you? Well, there's 2 cases there. And I want to ask you a question. What are the chances that this patient's going to get bowel cancer and die of colon cancer? 1%, 50%, or 90%? Well, all the literature, if you read, suggests that there's a relationship to familial adenomatous polyposis and Gardner syndrome and so forth. So, here's another case of chirpy.
Wait, before you mislead them, but it's not this type of chirpy. It's the different type of chirpy.
I think we were going to say that, weren't we? We were getting there. This is called chirpy in the literature, and this is another case of chirpy quote, and you can see it's different, isn't it? You see 3 lesions there near one another. See the white tail on them and so forth? In the literature, this has been called chirpy. But this is actually the condition, Gardner syndrome, in which they get about a 90% chance of developing colon cancer at a young and middle age, right? So that's what it looks like. It's different from chirpy. It's also chirpy, but the literature calls it that, which is not right. So RPE, hypertrophy with hyperplasia, FAP is part of Gardner syndrome, and what you see here is very typical. And if you see this, the patient is likely to get colon cancer by the time they're 45 or 50 years old. And their children, if they have the same thing in the fundus also, you can predict 30 years later are going to have colon cancer.
So what should you do for these patients? You get them tested genetically for the APC gene, adenomatous polyposis coli gene, and if it's positive, then by about age 10 to 15, they start screening the colon with colonoscopy. So, and they're at risk for this colon cancer by the late 20s, early 30s. So you really want to catch them early.
And to prove that, we did a study several years ago looking into that, and we looked at 100 cases that had typical chirpy seen on your left, and there was no relationship to bowel cancer at all. We looked at this one in the middle, that's multifocal chirpy, which is the same as what you call what? Bear tracks. No relationship at all. But it's these shown on the right that have a definite relationship to colon cancer, so it's unfortunate that in the literature they started describing this, and they used the term chirpy, which is misled, and our phones were ringing. Every patient with this condition thought they were going to die of colon cancer.
Yeah, it is unfortunate that they use the same term as the benign condition that carries no risk for FAP. So later they changed the term to POFL, pigmented ocular fundus lesions, but that's a bad term too, because a choroidal nevus is a POFL. It's a pigmented ocular fundus lesion. But whatever, we need a different term for these pigmented lesions because this carries a very serious risk for FAP.
Okay, now, I'm going to show an unknown and get the audience to help me out. How many retina specialists are here? You? Everybody, just about, right? Don't be shy. A patient presents with this. Can we get some help? Anybody want to talk about what this might be? Differential diagnosis? Anybody? Lymphoma? Okay, good. Multifocal what?
Even bird shot, sarcoid, I heard multifocal choroiditis, and I heard lymphoma. A couple of things in the differential.
Well, this patient was sent to us several years ago now with these findings in one eye, and the referring doctor was a very excellent uveitis specialist. And he said, we have done a workup for all types of uveitis and we cannot find any cause for this. Can you help us by doing an eye wall biopsy?